for joining us and giving us tips and tricks how to be a board top-notcher for the RTLE exam in the Philippines. Also would like to remind everyone to follow and support our social media pages, ang RTMO or at ang RTMO po, and our Filipino Association of Respiratory Therapists International at Filipino RT, and our Ang RTMO YouTube channel at Ang RTMO. So please do follow, subscribe, and help us with our advocacy here at Ang RTMO and at Filipino Association of Respiratory Therapists International. Also, I would like to ask for your good heart to continue to support our fundraising. It's posted on our social media pages. It's called the COVID-19 response to the Philippines. So far, just an update, we got $1,600 US dollars in monetary donations from our friends, colleagues all over the world. Thank you for your support. As of yesterday, as of 2 days ago, we have purchased 200 units of fingertip pulse oximeters from Alpha Centurion Medical that is based in Quezon City, Philippines. That cost us $904 for 200 units. So we have about close to $500 US dollars to spend. And if you haven't donated yet, please do so. We do appreciate your support. The donation will be received by the Office of the Vice President Lenny Robredo in Manila through the Angat Buhay program, particularly the COVID swab cab that is going around in the Metro Manila area where there is a high COVID-19 surge. So they're providing a e-consulta or e-consult for possible COVID-19 patients, and once the results comes back, they will be sent by the Office of Vice President a COVID-19 kit, which includes a pulse oximeter. So the pulse oximeter, as we all know, is very important in monitoring a patient's condition, especially the oxygen. So as you guys may know, in the Philippines, that there is a surge of COVID-19 and the hospitals are overwhelmed. So if you are not if you're a COVID positive patient and not requiring hospital stay, you will be recommended to isolate at your home or at isolation center, and you will be given by the Office of the Vice President if you are enrolled into their program, and that pulse oximeter will be very helpful in monitoring your health. So for all our donors, thank you so much. Maraming salamat po. And to all our to-be donors, please do support our fundraising. We will be ending the fundraising sometime next week. And the 200 units pulse oximeter that we currently have on hand will be delivered sometime next week. Please follow our social media pages for updates as we will document the donations and all the accounting, stuff that comes with it. We will remain transparent with our fundraising. And again, maraming salamat and thank you for your support. So on this show, towards the end of the show, as always, at every episode that we have a little game show, question and answer. So basically, our guests will ask you questions, and whoever gets the most answer will be receiving a prize. So for this time, we will be giving out a 1,000 pesos gift certificate from Shopee. So I will connect with whoever will be the winner today. Okay? If you guys have at any point have questions, please do let me know. I think I got disconnected. Please do let me know and leave your questions on the chat box so our guest and I can answer your question. Oh, I think I got disconnected again. Good job. I have a crappy connection here. But stand by. I think I'm still live. I'm just trying to go back to my control here, and we will be introducing and we'll be getting to know more about our guest tonight, Mr. Robb Bautista. Goodness gracious. Okay, this is the second time we're attempting to use Facebook Live and it's already giving me a problem. But stand by. stand by. Just stand by. If you guys have any questions, please do leave on the comment chat box. If we're having technical issue from your end, please do send me a message or leave a comment, and we will try to see what we can do about that. In the meantime, I'm trying to go back to my control room so I could continue with my live stream here. All right, stand by. This is the wonder of a live show. There's a lot of technical glitches. Okay, I still see that we are live. I don't know if it's being received from the on the other end, but I think it still is. I just want to verify. So again, I do apologize, and please stand by. Okay, I'm going back to the groups. Okay, welcome again to all our viewers as of this point. If you guys have any colleagues that who wants to join us for our tonight's discussion, please do invite them and send them the link of this show. We are currently live from California, and it's about 11:27 a.m. in Manila and 8:27 p.m. here in the United States. I will introduce our guests real quick once I see this event is still being streamed live. Okay, it's still happening now. I think we're still live. Okay, what happened here? All right. Mic test. That's mic. Sorry for the delay. Connecting live video. We're still live, I think. No, got disconnected. Sorry, Rob.
No worries.
Here. Got frozen here. Okay, sorry for the delay here, and sorry for the technical glitches. We're back live. Sorry. So again, thank you for all our viewers. Please, if you guys have any colleagues that who wants to join us, please invite them so and send them the link on this episode. We are currently live streaming in California. Sorry, got disconnected again from our Facebook Live. But without further ado, ladies and gentlemen, I would like to welcome Mr. Robb Bautista to ang RTMO show. Good evening, sir. Welcome to the show.
Good evening, and thank you, everyone. Thank you for welcoming me. Thank you, Michael De Peralta, for inviting me to the show.
You're very much welcome. Thank you for taking time and being, for accepting our invitation to be our guest for tonight. All right, now we're gonna start with the question and answer because you are ang RT. You are our respiratory therapist for today's episode. So, can you please introduce yourself to everyone, Rob?
My name is Robb Bautista. I've been practicing respiratory going on 10 years now. Been based out of here in the Bay Area the entire time. My father was a respiratory care practitioner as well, so I'm second generation. He primarily dealt with NICU, PICU. Myself, I do adult my specialty is adult critical care.
Hmm. Thank you so
Let me
much.
see what else. I also work. I work at a University of California, San Francisco.
All right. Thank you, Rob. Sorry, man. I don't see me going live right now.
Oh,
All right. If you guys can see me live, can you please leave a comment here? No, I don't know if this is a preview or. All right. Just stand by. What the hell happened? Sorry, man. I don't see. Oh no, I don't see me going live right now. Okay, we're live.
okay.
Sorry. All right, so that's Rob Bautista. Sorry. This is all right. If you guys can see me, all right, I can hear myself and see myself here. All right, second question, sir. So you said you're practicing at the University Medical Center based in San Francisco. Where are you from originally?
So I was born in the Philippines. I was born in Manila. Then my parents immigrated here to the Bay Area. So I've been raised here ever since.
Awesome. Thank you. Thank you.
I've
And
been primarily Daly City, South City.
awesome. Thank you. Thank you. And if we may ask, what from what RT school you graduated from?
So for my AS degree, I graduated from Skyline College in San Bruno.
Hmm.
My bachelor's in respiratory care, I did that at Boise State online.
Nice.
Then I'm still currently working on my master's degree at UCSF in epidemiology and biostatistics.
Awesome. Thank you. Are you trying to transition into research?
Trying to transition into research as well as I'm going to transition into teaching as well because I'll probably hopefully if everything goes well I'll be teaching at the respiratory program at Skyline in the fall.
Awesome. That's good to know. That's good to know. Thank you. And I think this is one of the questions that we ask for our guest speaker every time, or guest every time. Why did you know respiratory therapy before you enrolled respiratory therapy, and why? Why respiratory therapy?
Did I know what it was? Not
Yeah.
an idea. I knew I wanted to go into the medical
Mhm.
field, but wasn't sure where along the lines I wanted to go into the medical field. I didn't even know my father was an R. I didn't even know my dad was an RT until he's the one that pushed me into it. I knew he worked in the NICU and I
Mhm.
knew he worked with babies, but I didn't know what he actually did
Mhm.
until he finally told me. And then he brought me over to Skyline,
Mhm.
introduced me to the director, and then once I found out what respiratory was, I was just like, okay, this is something I can do.
That's awesome. That's awesome. Yeah, I mean, a lot of RTs didn't know what RT was before they enrolled. I think that there's at
No,
least, yeah, just a small portion, percentage of people, they know that they want to be RTs, before they enroll. But good to know. Thank you.
yeah.
And what do you think makes a respiratory therapist or the respiratory care profession unique compared to other allied healthcare professions?
A lot of what makes us unique compared to other professions is here, we'll take, for instance, we'll compare it to nursing.
Hmm.
Our physiology that we have to learn specifically about the respiratory system is we have to learn so much more about the respiratory system because I have a lot of colleagues that are in nursing. And when they tell me, I was just like, how much was your respiratory system or your pulmonary section? Either 1 week or 1 month out of their entire 2 year schooling. For us, it's an entire 2 year program specifically about the respiratory system. Well, specifically cardiopulmonary, but then how much we learn in depth about going all the way into the bronchi, subbronchi, terminal
Hmm.
respiratory bronchioles. So for us, it's a whole different atmosphere. And then when you talk about speech, when you talk about occupational therapy, physical therapy, it's different. It's not critical care.
Hmm.
When you look at respiratory, we deal in critical care. There's only three true critical care positions in a hospital: physicians, nursing, and respiratory.
Hmm.
So when it comes to what makes respiratory special, it's we're one of the three most critical positions in a hospital.
Agree.
That's why I appreciate it.
Yep, that's very true. That's very true. RT is a very unique profession, and we are specialized into the respiratory or cardiopulmonary care. So, thank you, Rob, for sharing that. And next question would be, as a respiratory therapist, working bedside, what do you think is your area of expertise? Are you a NICU, PICU, adult critical care, patient education?
For myself, it's adult critical care.
Hmm.
NICU, PICU, don't touch it. Don't want to see it. Not my world.
I Yeah, that's
There's
me
plenty.
too.
Yeah, plenty of people want to do that.
Yeah.
God love them because I don't. I,
Yeah.
I don't want to see kids, and
Right.
I don't want to see kids. I don't want
Hmm.
to see babies and that type of. But give me an old
Right.
person, a young adult,
Yeah.
middle aged, whatever you want.
Uh-huh. That's awesome. Yeah, that's me too. I've trained NICU, PICU. Yeah, but my heart goes to our bigger babies, the adults. You know, we have our own specialty. We all have our own area that we want to work, and adult critical care it is for us. Next question would be, as a respiratory therapist, what do you think is your most, personally for you, what is what he considered a special or a unique intervention that you can do as a respiratory therapist, or instances, as a respiratory therapist, what makes you, as you said earlier, what makes you important in a acute care hospital.
So in my hospital, we do a bunch of different adjunctive therapies.
Mm-hmm.
We do inhaled nitric oxide or INO therapy for
Mm-hmm.
INO gas therapy. We do drop esophageal balloons and do measurements through that.
Mm-hmm.
Uh, we also do the proning therapies.
Mm-hmm.
On occasion, we'll do APRV.
Mm-hmm.
Am I a big fan of it?
Yeah.
It's okay.
Right.
But as
That's
far as specialty stuff, yeah, we do a fair amount of nitric and we do
mm,
a lot of esophageal balloons.
awesome. And again, we're not advertising any particular brand here. If it was mentioned, it's merely conversation. So,
Yeah,
question that I have is, you guys use Hamilton G5 vents,
yeah, we use the Hamilton G5s.
and that's where you guys use the transesophageal balloons.
Yeah, we'll use the transesophageal balloons,
Mm-hmm.
and then you can do what they call the slow flow pressure volume curves.
Mm-hmm.
So another diagnostic tools that
Yeah.
you can do.
That's awesome. We're trying to get our hospitals or our intensivists to like that idea so we can, better intervene with our patients. But we'll see if it's gonna happen. All
Yeah.
right. um, I think we're going to our last questions, and we can proceed with the conversation regarding COVID-19 ARDS. Now,
Yeah.
Rob, if you may share, I know you are affiliated with our professional organization. Can you share that to us again? And your kind of like disclosure regarding that.
So my disclosures with
Mm-hmm.
our professional organization, I started off as a student.
Mm-hmm.
I started off as a student volunteer. I started off with the California Society for Respiratory
Mm-hmm.
Care, and for me, it was taught to me by my professors that you should be active within your own profession, because if you look at it, our profession started like here in the U.S. It started in the 1950s. It didn't go professionally into schools until the 1970s. So we have one of the youngest professions in the hospital, yet we have one of the most important professions in the hospital. Being one of the more younger professions that we still have the opportunity to shape where our profession is going to go.
Mm-hmm.
So for myself, knowing that I have the ability, or I have the chance to help shape where my profession is going, so I can know where my future is going to go and help us secure our position for the future. That's why I stay with our professional organizations.
Awesome. Thank you. And so you
So
wish. Mhm.
I said, so, oh, I was going to say, so for myself, I started off as a volunteer,
Mhm.
and then I became the G bar. I became our regional president.
Mhm.
Did that for 4 years. I'm currently running for our national society's delegate.
Mhm. Awesome. Thank you. Thank you. And yeah, so if I can share to our audience, Rob is currently, he's one of my mentors because disclosure, just sharing information that I'm currently the Greater Bay Area Region President, and I just, and Rob Bautista is our immediate past president of the Greater Bay Area Region for California Society of Respiratory Care. Thank you, thank you, thank you. And that's, very, you're a very good mentor, very, you love the profession and you are doing something right, to advocate for the profession here in the state of California, and as well, in the national level too, because it goes there too. So last question for you, Mr. Rob, is what is your message to our current respiratory therapists that are watching us right now, the student respiratory therapists and the current respiratory therapists colleagues that are watching us now?
So for all the respiratory care practitioners and students out
Mm.
there, just keep studying and studying hard, and for yourselves, don't stop at the AS degree. If there's a possibility to get a bachelor's in respiratory care, seek it out if you don't already have a bachelor's. And then once you get there, don't stop. Get a master's. Keep educating yourself because
Mm.
nothing can be better for your patients or for yourself than further education.
Mm.
Go to conferences.
Mm.
It's better now for students because we have a lot more conferences that are online. You have the ability to learn without having to leave your home.
Mm. All right.
So if I have a sending message, it's and on top of that, if you are taking care of COVID patients, especially if you
Mm.
don't if you have limited resources, be safe.
Mm.
Be safe, take care of yourself, make sure you're well because if you can't take care of patients, that's harder for the patients.
Agree. Agree. All right. So, thank you so much for answering my questions and sharing it to our audience tonight. And now, to our audience again, we will be proceeding with our conversation regarding management of COVID 19 ARDS momentarily. If you guys have any questions at any point, or if you are planning to, what do you call this? If you're planning to ask a question, formulate your questions now, and please feel free to comment down on our section or comment section below, and we will answer your questions. Okay. All right. So again, thank you so much for your time. And now we will be proceeding with our COVID 19 management or management of COVID 19 ARDS. So take it away, Rob.
Okay. Let's start about this time last year. We didn't really know what was going on. A lot of stuff was happening with COVID ARDS. It happened in what? And started in December of 2019. It was coming out of Wuhan, China, and then it wasn't in here until the Bay Area. We didn't get our first sighting of COVID until March, and it was only one case in Santa Clara County. But come March, April, it starts rolling around, and then we start seeing breakout cases all throughout the country. Luckily enough, in the Bay Area, we didn't see the huge surge that other country or other states and other countries saw. New York being the worst of them. So what we did is we also sent a contingent at UCSF to New York. And then when they came back, they told us all the different stories. And the crazy part was hearing that hospitals in New York had 70 plus COVID patients vented and only 3 RTs for the entire hospital. That's because the hospital couldn't afford to get enough help to the hospitals in time. They also didn't have enough ventilators to take care of the patients. But what were we learning at that time? So during that time here in the US, they were giving out grants and tons of money for research. Where was a lot of the research going on? It was going on in Italy, it was going on in New York, and it was going on in the East Coast as well as the Pacific Northwest, because that's where the major outbreaks were. In California, our prevalence was still fairly low. So in the beginning, what was a lot of the research going on with? In the beginning, you might have heard of the research of like the H and L phenotyping. H and L phenotyping was predicated by two authors, Luigi Camparata and Luciano Gabnoni out of Italy. So what they were stating is COVID was slightly different than from conventional ARDS. So what they were stating is there was two types of patients in this phenotyping, the H phenotype and L phenotype. H phenotyping being high compliance, low oxygen needs. So almost a normal patient, but just a little increased oxygen needs. And then there was also the low compliance, which mimicked what was going on with ARDS. And what they were saying is people started off in the H and then progressed through like what they call PCILI, or patient self-inflicted lung injury, because they would start inhaling and the negative pressure would cause negative pressure pulmonary edema and then hurt themselves. But then there were a lot of other researchers that were talking about this. So now think about it. When we look at ARDS, acute respiratory distress syndrome, what is its primary source? There is none. It's a syndrome. Being syndromic, it's made up of different types of disease processes that are happening to them. So, because what are the four main types of disease processes, or not disease processes, or just where do we get ARDS? Pneumonia, aspiration pneumonia, trauma, and sepsis. Now, COVID ARDS, is it truly ARDS in its sense? Yes, because it still falls into the criteria. PF ratios running less than 200. Bilateral fluffy infiltrates or diffuse bilateral opacities. And you're getting pulmonary edema that's from a non-cardiogenic origin. So does it still pass the criteria for ARDS? Absolutely. But is it slightly different? Absolutely, because it's coming from a different etiology. It's neither pneumonia, aspiration pneumonia, sepsis. Well, you can argue you can get fairly septic, and it's not trauma. But you are still getting some of the different, you are still getting symptomatic, and you are still falling into the category of ARDS. Now, when you look at traditional ARDS, how do we treat it? When the patients first come in, you give them oxygen, and then you start giving them high flow oxygen, because it's all oxygenation needs. And then you progress on to, sometimes you will go non-invasive, and then you would progress on to go to mechanical ventilation. But what was the issue with COVID ARDS is we didn't know the actual infection route. We weren't sure. Was it droplet? Was it airborne? Was it strictly contact? So in the beginning of this pandemic, we were super conservative in how we are doing this. So what happens with COVID ARDS and how do we treat it? We go from high flow. We are no longer doing non-invasive ventilation, because the way to try and ventilate a patient with non-invasive ventilation is it's usually a single limb circuit that's not filtered on the way out. So if you can do non-invasive with a dual limb circuit where the exhalation port is filtered, by all means, they were trying it. And then we would go straight to mechanical ventilation, and with mechanical ventilation, we would almost already go to ARDS, because by the time people would progress from high flow nasal cannula to ARDS, we are starting to see PF ratios sub 150, which clinically shows that they are in the higher, their compliance is decreased, they have higher elastance, and then we need to start going on higher levels of PEEP, and then we need to start going to other adjuncts. Other adjuncts being proning, esophageal balloon, the high PEEP grid. So different things. So if you look at proning, where do we get our protocols for proning? There was a study paper, and I believe it was around 2013, 2015. It was the Prosiva trial out of France. And then with that one, it showed that if we go into proning, we're going to prone for at least 16 hours a day. And then the rest of the 8 hours, where the 16 hours a day, as much as 20. So between 4 and 8 hours, you would have the patient supine. Luckily enough, here in the Bay Area, we had enough time and resources. In New York, Chicago, Detroit, they didn't. So a lot more people died. Their mortality rate was upwards of 60%. In the Bay Area, we got lucky. Our mortality rate was like in the 20s. At UCSF, we were about 15 to 20%. So we had a low rate because we had a fair amount of patients, but we had a lot of time to deal with them. Our normal course for a COVID patient in our ICUs, once they get ventilated, because we would have them on high flow on average probably about 4 to 6 days, and then we would go straight to mechanical ventilation. And for our sickest patients, since we are a tertiary care center, so we don't do direct admits for COVID in most cases, we're getting transfers from other hospitals. These patients have already been ventilated for at least a week. They're coming in with PEEPs greater than 12. They're already at 5 to 6 cc's of tidal volume. Their compliance is about 30. Plateaus right at about 30 centimeters of water already, sometimes 35 or greater. So what was our normal course of action? They'd be ventilated for greater than 3 weeks. We've been proning them for greater than 2 to 3 weeks. We're initiating paralytics for greater than 2 to 3 weeks, in which normal course for paralytics is probably 3 to 4 days. We're doing it for 2 to 3 weeks. We're doing high-dose fentanyl, high-dose Versed, high-dose propofol as long as their triglycerides can handle it. And we're proning them for the entire 2 to 3 week period. And what we started finding out is, for some odd reason, maybe it was the body finally healed itself from COVID, but after 3 to 4 weeks, they finally started to turn the corner. But that's the hard part is, we tried titrating little by little each day. In the beginning, it didn't work. The patient they would drop their sats into the 80s, drop it in sats into the 70s. They didn't tolerate it. So what we had to do is we had to hold the course for 3 to 4 weeks. PEEPs anywhere from 12 to 20, 100% the entire way. Proning for 2 to 3 weeks. Facial edema, complete swelling. You had to do it. But after 3 to 4 weeks, they finally started turning the corner, and then we were able to finally wean down these patients, get them back down to high flow off of there, and then wean them down back to regular nasal cannula. And of course, they're going to require tons of rehab, because even if you look at the study from 2005, 1 year post ARDS, post severe ARDS, after 1 year, they can return to almost normal function, but at the same time, their pulmonary function for advanced activity is completely decreased. They've returned back to work, but they can barely do any strenuous exercise. So for these patients, we know it's going to be a long road back. It's going to be a hard road back, but that's what it is. Because what therapies were we doing along the way? We're doing proning. We're doing inhaled nitric oxide, because we don't have flow line at my institution. We're not doing inhaled prostacyclins. We're doing the high PEEP grid, which is the alveoli trial. We're doing esophageal balloon therapy to help guide us in certain cases where we have obese patients. In certain cases, at the very extreme cases at the end, we also do ECMO, extracorporeal membrane oxygenation, which is another therapy. And in that case, we're basically doing another set of lungs outside of the body, because It involves oxygenation and then CO2 sweeping, so it'll do ventilation outside of the body as well. That's in rare cases we would do that. We're in that case we're considered a ordinary care hospital because we're doing extra specialized care for those patients. But what did we learn in the end? These are still COVID patients. These are still ARDS patients. When it comes to treating them medically, what are we doing? We're doing convalescent plasma. We're doing steroids. We did the dexamethasone. How much did it help? It helped a decent amount. We did the remdesivir. I'm not too sure. We're still doing, I believe, the 5 to 7 day course of remdesivir. We're doing that for them. We for a time we did start having a shortage of, like, I believe there was fentanyl and Versed shortages, so we had to start figuring out different types of sedation. But these people were on high amounts of sedation. 400, 500 of fentanyl, 12 of Versed, like 100 of propofol. And on top of that, they're still on paralytics with cisatracurium. But the main thing is patience. Do adjunctive therapies, do it early, and make sure that you just stay the course and make sure you have what. The hard part for my institution is we had a lot of resources and we had a lot of time. I know there's a lot of institutions out there that don't have the same resources. So you have to stay vigilant in what you have and reach out to others when you get put up against the wall to see what else you can do. But other than that, it's it's basically ARDS as usual.
Mm-hmm.
Anything you want to add in, Mike?
Uh, Wait, I'm muted. Hold on. Uh, no. So you brought up a lot of good points in here. Um, so what you guys are doing at your institution is normally what we do in ours to accept that we don't have the capability of, say, ECMO in the esophageal balloon. But you brought up really good points on what do what are the treatment, and proning, inhaled nitric, high PEEP strategy, esophageal balloon, ECMO if needed be, and then you guys do convalescent, dexamethasone, remdesivir, and a lot of sedation and paralytics for our patient. Pretty much that's what we do now, and it's crazy that we are into this pandemic, because as you know we know there's no treatment per se directly to target the COVID-19. What we're doing is treating the side effects of COVID-19, and AR they present as ARDS, then we'll treat them as ARDS, right? They have decreased oxygenation, we provide them the PEEP and the oxygen that they need. Their cardiac, their pulmonary artery might be, what do you call this? Might They might having some pulmonary hypertension due to a a COVID-19 effect. Then we provide them inhaled nitric. So, you brought up a lot of good points. Now I'm gonna ask our audience if you guys have any questions. Please do ask Mr. Robb Bautista here and we will be catering your questions to the best of our ability and our experiences. So please feel free to comment or to ask us any question. So, to keep the conversation going, did you guys have a lot of patients that needed to be put on extracorporeal membrane oxygenation?
So from other institutions, we've had, because we're also a referral center,
Mm-hmm.
so we've had a fair amount of people refer their patients to us for evaluation of extracorporeal membrane
Mm-hmm.
oxygenation. But in the end, we've probably had 5 total
Mm-hmm.
at most,
Right.
maybe even less. But as far as intubated patients, we've had a lot because when you think about it, when we do respiratory care, what's our main things?
Mm-hmm.
Oxygenation and ventilation.
Mm-hmm.
When you do high flow nasal cannula, you can provide oxygenation. And then what's the reason you intubate? Because we can no longer help you out with ventilation. Your body's giving out. So at that point, that's when you intubate a patient, when you can no longer meet their work of breathing without any other adjuncts.
Mm-hmm. That's good. Thank you. Thank you. And also, what do you call this? So for ventilation strategy on your COVID-19 and they present as ARDS patient, uh, you guys just follow a kind of like ARDS ARDSnet protocol. Do you guys have your own ARDS protocol?
Yeah, so with UCSF was one of the original sites for the ARDS protocols back in the early 2000s.
Mm-hmm.
The two main trials being the ARMA trial and then the alveoli trial, more commonly known as like the low PEEP grid and the high PEEP grid. ARMA was the low PEEP grid, 6 cc's, the tidal volume,
Mm-hmm.
and then the ARMA trial was the high PEEP grid. So we followed that
Mm-hmm.
fairly closely. But what we every but with these COVID patients, sometimes you have to get off grid
Mm-hmm.
because they're not always going to be normal patients.
Mm-hmm.
They're not always going to fall strictly within the guidelines.
Mm-hmm.
You have to understand the physiology and understand that sometimes the PEEP and the compliance effect that you need to stay at higher PEEP just to maintain that compliance,
Mm-hmm.
and then that you can wean the FiO2 a little bit more judiciously when you get the compliance to a better place. But do we stay within those guidelines for the most part? Yeah.
Okay. Thank you. And we'll just read comments from our audience here. It's from Gomez. Said, "Sup, Rob?" And then we have a question from Jezebel Ascalani here, our fellow RT colleague from the Philippines. Good morning, Sir Rob. I have a question. Let's say the RT did all the interventions and treatments for ARDS, but still there's no improvement at all. Based on your critical care experience, what is the last resort for ARDS?
The absolute last resort, if you have it available to you, is ECMO.
Mm-hmm.
Now the proof and the so a lot of people are going to resort to what they call the Eolia trial. The Eolia trial was released 2018, I believe, and it shows a neutral. It's what they call like a negative trial because it's neutral effect. It doesn't show that there's any true mortality benefit. But the main thing is you try all your interventions, you do everything you can,
Mm-hmm.
and you have to stay patient.
Right.
Because if there's one thing that this pandemic has showed us, especially with ventilation, is you have to be patient.
Mm-hmm.
Sometimes it can take 3 to 4 weeks
Mm-hmm.
of hardcore mechanical ventilation before you see them turn the corner.
Right.
But the other part is yes, if you can do ECMO, if your institution can do that, which it's hard to say because there's only in the world, this is what I found out recently. In the world, out of everyone we can do, we only have enough resources
Mm-hmm.
currently for 12,500 people to be on ECMO.
Mm-hmm.
That's it
Mm-hmm.
in the entire world.
Mm-hmm. That's
But
good.
as a
Mm-hmm.
as the most serious
Mm-hmm.
of all the adjunctive therapies, ECMO is the most serious.
Mm-hmm. All right. Thank you. Thank you. And thank you, Jezebel Ascalani, for your question. Hope that answered your question. And for our audience that are watching live, feel free to shoot us any questions on the comment section, and we will try to answer your questions. And adding it onto that is, as you mentioned, especially the ECMO. I did a very short gig as an ECMO specialist, and we've done it on kind of like what is that? Bay Area, kind of like a South Bay. So personally, I personally assisted and placed and managed patients on ECMO, And that's what I do as a respiratory therapist, is just to sit on that ECMO machine and do and try to ventilate and oxygenate them from there while their lungs are being rested. They're on a rest, the lung resting strategy for ECMO. As you mentioned, and on some research too, that yeah, it's a negative trial. It doesn't necessarily, at least on my experience, it doesn't necessarily help with the mortality rate. You know, you know, but at the moment you just see, because you can control outside your vent and outside the body, you can control ventilation, oxygenation. Personally, what I feel on that is it's just kind of like a band-aid solution. And then later on you put them out on the vent, you decannulate them, and then same thing happen again. And as you mentioned, Rob, COVID-19 patients won't present normal, especially when they're critically sick. I think patience is really the key for that. Is you do your ventilation strategy, your ARDS strategy, and then just wait. Now my question to you, Rob, what is an acceptable pH? What are you guys targeting for pH in your institution?
What's acceptable, or what do we tolerate?
What
There's
do you
two
guys
different
tolerate?
questions.
Let's be clear with the
Uh,
words. What is tolerable for you guys? I mean, as you mentioned, we don't target for
so
normal numbers, right?
what's the at the back end of the spectrum, what we're willing to tolerate,
Mm-hmm.
or what is about 725 is what we're willing to tolerate.
Mm-hmm.
But what we have to deal with, we've dealt with patients as low as 715.
Mm-hmm.
Is it the ideal scenario?
Mm-hmm.
Not as much, but 720, 725 is about where we feel somewhat comfortable, because in normal circumstances, once you get below 725, you start denaturing the drugs.
Mm-hmm.
So then vasopressors don't work as well, and other drugs also get denatured. So the efficacy of drugs becomes less effective. So at below 725, it starts getting bad.
Mm-hmm. Awesome. Yeah. Same for us too. In our institution that I won't name, we're not targeting normal numbers, and we follow greater than 7.2, 7.20 and above will be fairly tolerable for our intensivists and for our patients, because as have you seen also, like this people won't, they'll have very high CO2 regardless if you're giving them 6, 7, or 8 mils, and sometimes even a respiratory rate of 30 don't help anymore. But then again, it's kind of like magically the medicine is really hard to explain onto this, but it's kind of like magically after so many days and weeks, you'll see them progress, and personally feel that it's kind of like their body is kind of healing and getting away from COVID, and they're trying to go back to their normal, their normal, what do you call that, their normal state, and we can ventilate them better and oxygenate them better. But the first few weeks of them being intubated, especially when they're critically ill, it's just very hard to catch them. But yeah, any more questions from our audience? Please feel free to ask any questions. In Manila, I'm not
Because
so sure. Go ahead, go ahead.
now I was going to say, one of the main things for people out there to possibly do is, if they can trend dead space for the patients,
Mm,
because that's been one predictor of mortality
mm,
that's easier to measure. If they had the ability to do that through either volumetric capnography, or
mm,
there's another way to measure it. There's other ways. There was a paper in 2005 by a gentleman named Jeremy Beitler that showed different ways to measure dead space that are estimated through different means, because dead space is one of the biggest predictors of mortality.
mm,
Once you get to 60%, 70% dead space, your mortality increases by orders of magnitude, and it's just horrible. So
mm,
if they can learn more about dead space, figure out how to trend it, it'd be better off for themselves and for the physicians as well.
mm. Thank you, thank you. And then, all right, for our audience, you guys have any COVID 19 ARDS related questions, please shoot us a message or a comment here on Facebook Live on Ang Artimo. And thank you for joining us tonight. We're still here with Mr. Robb Bautista with a conversation on management of COVID 19 ARDS. COVID 19 ARDS. So, yeah, in the Philippines, that right now what they're dealing with, you know, same in the United States. When we first had this big surge, we didn't have enough resources. That we scattered of getting ventilators, borrowing from another state, or loaning to other states. And we didn't have. We have to get ventilators out from schools and universities and borrow them so we can use them for our patient, because the initial strategy that we're using, as we don't know COVID that much yet compared today, is you have COVID, you're desaturating, right? We intubate you right away. And that's what we've been doing before. And now in the Philippines, you know, not only the cost of healthcare is very difficult in there, it's like it's a meter, right? Everything that you do, especially when you're a private hospital, you gotta have
Charge.
to pay for it, and that includes the PPE. And that's the sad reality of the healthcare system in the Philippines, and not only in the Philippines, even surrounding country too. Even in the United States, even if we have our private healthcare insurance or the government sponsored healthcare insurance, we still get billed. But in the Philippines, you gotta have to have these resources, or if you want to live, then we'll scatter. And right now, you gotta have to find your own ventilator and have somebody operate it. And that's the sad reality now, because how severe the hospitals are overwhelmed by the COVID-19 patient. Now, reading from a comment from Mr. Andy Palado. Hi, Michael. It's me again. What is your comment, opinion to an institution on where they keep the patient awake and patient is intubated and ventilated? Looks like they are scared of sedating the patient. And it is a COVID patient. What's your take on that, Rob?
So the more this is a hard part because
Mm-hmm.
my take on keeping a patient awake,
Mm-hmm.
especially if they're intubated and they have severe ARDS, it's not right.
Mm-hmm.
Because to properly treat a patient with ARDS, you need to treat them with low tidal volumes, 6 cc's or below. Now, as we're awake, we're alive and walking. Yeah, we can tolerate 4 to 8 cc's when we're walking around.
Oh, Rob.
Your need for
Okay.
oxygen is greater.
Sorry. I lost your audio. Okay. Okay.
Well, I'm coming back on.
Okay, good. I can hear you now.
Okay, is it back on?
Yep.
So when you look at it, you're starved for oxygen, you're needing more ventilation, your work of breathing is going to increase. That it's the what you're going to deal with is not sedating the patient is not right
Mm-hmm.
because the patient is going to fight the ventilator, and it's going to lead to other injuries because there's a lot of studies that show patient ventilator asynchronies
Mm-hmm.
are another reason people get worse
Mm-hmm.
because you're going to get more barotrauma, you're going to get volume trauma,
Mm-hmm.
and it just leads to worse outcomes, especially in the beginning. Because when we were talking about it, how much we sedate the patients just for them to remain synchronous with the ventilator, it's insane.
Mm-hmm.
Now, if you don't have those same resources, it's hard for me to discuss or what other ventilation strategies you're going to have to do.
Mm-hmm. Thank you, thank you. Yeah, that's very true. Being on a ventilator is not comfortable, number one, and being sedated is, you know, I truly believe that being on a ventilator myself twice already, that you gotta have to be sedated so you can continue on, you know, synchronizing with the vent so we can achieve our ventilation. You know, the strategy that we're doing or the settings that we put on. Um, mm, Yeah, so there's a follow-up question. The next thing is, this is due to financial reason as well. So, you know, as mentioned earlier, that anything that you do there, you gotta have to come up with, money. Unfortunately, you want to sedate your family member, then here's what we need, and provide it to us once you have it. It's kind of like that. Your patient, your family member needs to be in a ventilator, then you'll get a consent, and unfortunately, it comes with a cost. So that's a very hard question there. And there's only so much that a healthcare professional can do. They give their suggestion, this is what we're going to do, and then you'll give them a fighting chance. But then if it's a financial reason, that's another aspect of it. Now you want to ask yourself, as a family member, would you want your family member to suffer and give them the quote unquote fighting chance, or give them the fighting chance not being on a ventilator, because it's very painful and very uncomfortable to be on a ventilator, especially when we're trying to ventilate you and oxygenate you on higher settings. All right, any more questions? Keep the questions coming here. We still have Mr. Robb Bautista here joining us. Guys, have any more questions, please feel free to leave a comment and a question or a comment section below. um yeah, you know
The other hard, I was going to say the other hard part about it
mm,
is you're talking about little to no sedation. Is you have to remember these people are in a hospital room,
mhm,
sometimes with windows, sometimes without.
mhm,
So their idea of their time and space becomes inordinate. So you have to start worrying about delirium because ICU delirium is a serious thing, and
mhm,
it's going to be something else that we have to treat later on.
mhm. Yeah, agree. Thank you. And then, oh, I thought we had some question here. Any more question from our audience, or anything else you want to share, Rob?
The biggest thing is not everyone's going to have all the resources in the
Mm-hmm.
world. We're lucky here in the Bay Area. I'm lucky at my institution that I have basically an unlimited amount of resources that I can use to help treat patients.
Mm-hmm.
Some of the people aren't as lucky. So understand what are your limitations, what you can do, and when you get stuck up against the wall, reach out to others that have other experiences or
Mm-hmm.
see what else we can do with you.
Yeah. And also a reminder to our audience, we're here having conversation, we're sharing our experiences. We're not telling you what you need, or what you need, the do's and don'ts. We're not telling you what you need to do or what you must do. What we're doing here is having a conversation, so we could, hoping that you guys could get something from us that you can use on or your institution, or not, right? Because, again, every institution is different, and as well, at the end of the day, we're respiratory therapists. We still work under the license of a medical provider. So whatever the medical doctor says, that's what we need to follow. But we have to what we have to understand, and what we need to practice is, as respiratory therapists, as specialists of the lungs, right? We need, we're hoping that our medical providers or medical doctors would listen to our advice and our experiences and our knowledge in caring for patients who are actually suffering from respiratory therapy disease. So, oh, here, there's a comment here. Good afternoon, Sir Michael, Sir Rob. I would like to ask, how should we titrate the PEEP? Should we still follow the ARDSNet protocol?
In most cases, it'd be best to follow in most cases, it's best to follow the guidelines because the guidelines have proven to show a decrease in mortality. In fact, it was one of the best decreases in mortality that our profession has ever shown. If you follow the ARDSNet protocol, it shows a decrease in mortality of about 30%. You're giving your family members a 30% chance at increasing better. Now, if you're at an institution where you have other devices like esophageal balloon, you can titrate. You can try to titrate off of that as well. But if you have limited resources, the best thing to do is yes, follow the ARDS, follow the ARSNet guidelines.
All right. Thank you, Rob. Thank you, Mr. Goji de la Cruz, for your question. Yeah, so if any of our audience still has any questions, please feel free, to ask question. We will still be available for a question in, a few minutes here. And yeah, it's just do, you know, just do what you can to help your patients. And again, as a respiratory therapist, we are also patient advocates, right? We could advocate so much, to help our patients to get better and do all the treatments that we think is necessary or would be helpful for their current condition. But then again, the sad truth about that is it comes, with a cost as well. So that is a very sensitive topic. We cannot tell you what you need to do, but it's very important for your medical providers, and your patients and your family members have to understand that the reality, that the possibility of their outcome with that. So would you want your patient to suffer more and give them a fighting chance with less of a resource or not enough resource in your current institution or their financial capability? Or would you like, unfortunately, your patient to fight off and hope, and pray for the best outcome that they could receive? Because again, that's a question that is hard to answer, and if there's an answer to that even. All right. So just one more. I have a question for you. I think our audience have heard it earlier, and for your proning strategy, Rob, you mentioned how many hours prone and how many hours supine.
Minimum 6 hours, minimum 16 hours prone,
Mm-hmm.
as many as 20 hours. So
Mm-hmm.
between 16 and 20 hours prone, which would leave you, what's that, 4 to 8 hours,
Mm-hmm.
4 to 8 hours supine. In the beginning of the proning, you try and get as close to 20 as possible.
Mm-hmm.
The longer time they have prone, the better it is. And for you to determine whether proning's working or not, you do a pre-proning, do a do a ABG when they're still supine, flip them over, go into prone position, wait about 30 minutes to an hour, do a post proning gas, and do a
Mm-hmm.
comparison.
Mm-hmm.
In most cases, if you see a 50 to 60 increase in PaCO2 or in PO2, it's usually a pretty good sign, especially if they're on 100%.
Mm-hmm. All right. Thank you for clarifying and reviewing that prone strategy. Thank you. All right. I think that's about it for our question and answer and conversation regarding this topic. If you guys have any more questions, please feel free to leave a comment and we will try to answer you guys on a later time or date. Leave us a comment here and we will try to get back to you when we can. And again, thank you for watching us live from wherever you are, and thank you for engaging with us, with our audience today. And continue to support our channel on RTMO, our group, Filipino Association Respiratory Therapists International, and our YouTube channel on RTMO. If you guys have any question, concerns, or suggestion for our future episodes or our current episode right now, please shoot me a message on my actual Facebook account or on Artimo. The Artimo page can receive messages as well. All right, so yeah, Mr. Jello Gomez. Unfortunately, we can't comment on that.
So for those of you who don't know, Jello works with me he's one of my coworkers at UCSF as well.
All right, is he a Filipino American too?
No, no, he was born and raised there.
Yeah, awesome. Thank you for joining us tonight. So, oh god, yeah, we're gonna get in trouble here, Rob. But anyway, yeah, feel free to read that comment and yeah, and have an interpretation onto that. All right, now for our audience, in the Philippines, unfortunately, we have to limit our contest and our, prizes for our colleagues in the Philippines right now, as we are giving a gift certificate that is based in the Philippines. Um, we will kind of, we'll start with. You have questions prepared for us, Mr. Bob?
Yeah. I got a couple of questions here.
All right. So mechanics of the
So,
game is for our audience. Mr. Rob will ask you a question. Whoever gets the correct answer first will get the point. So how do you get a point? Just leave your answers on the comment section, and whoever pops in there first, who got the right answer, will get a point. Whoever has the highest point will get our prize. And for tonight's episode, our prize will be a 1,000 Philippine pesos Shopee certificate, e-certificate. So Shopee is kind of like your Amazon, or your Amazon based in Asia. So pretty useful for a lot of people there. You don't have to go anywhere. Just click on the app. We're not promoting them, but that's what they do. So, click on the app shop and they'll deliver it to you. So that would be our prize for tonight's episode. So if you guys are ready, please ready your fingers, and whoever gets the first answer, correct answer, will get the point. Go ahead with your question, Mr. Robb Bautista.
so for first question, who is one of the authors of the H&L phenotyping paper for COVID that I stated earlier, out of Italy?
That's a hard question. Can you give us
Well,
options A or B?
okay, here we go. Multiple choice. Two of the answers will be right. One of the answers, or two of the answers will be wrong. There's option A is Laurent Brochard. Option B is Luigi Camparata. Option C is Martin Tobin. Option D is Luciano Gattinoni.
All right. A, B, C, or D? I always ask hard questions. All right. Give you a few more seconds to answer, folks. In 5, 4, 3, 2, 1. We don't have any answer on that. What's the correct answer?
The answer is either B or D.
Oh,
You
B or
can,
D.
if you took B or D, were both correct answers.
Mm-hmm. Cool. Next question. Thank
Okay.
you.
Yeah, we'll make it a little bit easier. Should you put a patient with COVID on non-invasive ventilation? It's only a yes or no answer.
Mm-hmm. Should you put a patient on a non-invasive ventilation? Yes or no? Come on, we got plenty of audience here. Put some answer in there. I don't know if I'm getting delay, but usually we get a lot of people. They might, our students. I think they're in a. Oh, here we go. We got an answer. Andy Pallado, no. Christopher Lim, no. Chewy Engal, no. Let's give you a background. Mr. Andy is based in Saudi Arabia currently. Christopher Lim is based in Canada. Mr. Chewy in Manila. And Tim Davis, based in U.S. Tina in the Philippines, no. Any of them got the right answer. They're all no's.
As long as they said, yeah, which is completely the right answer. If you can avoid non-invasive ventilation with COVID patients, that's the absolute best thing to do. Go straight from high flow, and go straight from high flow to mechanical ventilation.
Awesome.
Because You're only prolonging the inevitable and making it worse for the patient.
Yep. Awesome. Because the question is, should you, right? No, but can you? That's a different answer to that.
Yeah.
So we'll give Mr. Andy a point there. Hey, Mr. Andy, you got 1 point. Next question.
The next question: is COVID ARDS? Yes or no?
Yes or no? While we're waiting for answers here, would like to shout out our colleagues from the Middle East, Asian countries, in the Philippines, in Canada, in the United States, wherever you are watching tonight. Please stay safe. Please do take care of yourself. Again, if you can't take care of yourself, how would you take care of others? So we want you to be safe so you could be a useful resource for us fighting this pandemic. So we have an answer yes and no. What is the right answer? We both got yes and no. All right, I think that's about it. What's the correct answer?
So the correct answer is still yes. Does it fulfill the criteria? Absolutely.
All right.
Are patients with PF ratios less than 300? Do they
Mhm.
have diffuse bilateral opacities? And do they
Mhm.
have pulmonary edema stemming from non-cardiogenic sources? Yes.
Awesome. So there we go, Mr. Andy. Got another point. You have more questions, Rob?
Here, what is one of the primary adjunctive therapies for COVID ARDS? Adjunctive meaning, what's one of the ones that we're using that's not a ventilator? What's one of the other therapies that we use? What's one of the primary therapies that we use for COVID ARDS?
Hey, we're waiting on answers. Speaking of non-invasive ventilation, I don't know if you have seen it, Rob. It was posted on RT Break Room, also on our party page. It says non-invasive ventilation. It's a magazine by our the national organization of our colleagues in healthcare. But the picture is a aerosol mask with a nebulizer cup, and it says non-invasive ventilation.
Gee,
Crazy. It's yeah.
I will leave that one alone. Not touching that one.
Right. All right. We got answers here. Proning, high flow. I don't know what JP said. Christopher said, no idea.
Well, whoever put proning.
All right. Whoever put proning? Okay.
Yep.
Correct answer is proning. Mr. Andy. Awesome. Oh, can you, Rob, we already got a point for somebody, but one of our colleague here is asking, can you repeat the question and the answer?
So the question is, what is one of the primary adjunctive therapies for COVID ARDS?
Mm-hmm.
And then the answer is proning.
Awesome. Thank you. Thank
Because
you.
it's one of the most widely available. All it requires is just manpower or person power. Let's be politically correct.
Cool. Thank you. And do we have more?
Yeah, here's another one. When we're talking about adjunctive therapies, we're talking about using a gas with the letters that be with the initials NO. What does NO stand for?
What does that NO stand for? No.
and it's a gas.
What does NO stands for? All right, we got a answer here. Nitric oxide from Chewy, from Mr. Andy and Christopher
There we,
Lim and Alparas. Nitric oxide. Jessica Ascalani.
there we go.
All right. Chewy gets 1 point. And do we have more?
Here, we'll ask another. Yeah. Do we want an easy or a hard one?
It's up to you.
Here we go. We'll give a hard one, but I'll do multiple choice.
Mm-hmm.
What is the name of the paper that details the therapy for proning in the setting of ARDS? So, what is the name of the paper that details the therapy for approving the trial in the setting of ARDS for proning? So, the names of the papers: A. Eolia, B. Prosiva, C. Oscar, and D. Oscillate. So that was A. Eolia, B. Prosiva, C. Oscar, and D was Oscillate.
All right. Got 4 options: A, B, C, or D. You got A here. All right, let's wait for other answers. All right. Only 4 letters: A, B, C, or D. B? Nobody wants to answer C or D? All right, I think that's it. What's the answer, sir?
The answer is B. Prosiva.
Prosiva.
The Prosiva trial out of France, headed by Claude Guérin.
All right, we got a clear winner here, Mr. Andy Palado, from, I believe, Saudi Arabia, based right now. So here's the deal, because we have what do you call this? We we appreciate your engagement and your answers to this, but we are trying to limit our prices to our colleagues in the Philippines. So if you, I will communicate with you, sir, and then if you can refer what do you call it, a proxy for you that's based in the Philippines, that we be good. Oh, from UAE. I'm sorry, you're from UAE. Thank you. So we'll communicate offline, and we can get a proxy that is based in the Philippines, so they can enjoy the gift certificate based in the Philippines. So I'll communicate with you offline. So again, Chelo was like, Rob, can you repeat the question in Tagalog? Yeah. Do you speak it, Rob?
No, unfortunately not.
Oh God! All right. So again, I'd like to thank all our viewers for this afternoon episode, wherever you may be. We appreciate your engagement, your support, and with our show here. We do appreciate all of you. So, and congratulations to Mr. Andy Palado, based in United Arab Emirates, our fellow colleague, Filipino colleague in United Arab Emirates. Please do stay safe there, sir, and as well to all our colleagues that are and supporters that are watching right now. So, and shout out to my colleagues here, JP and Jonathan. They're very good people. my former students here. So yeah, thank you. So anyway, you have any closing remarks, Rob?
Stay safe and keep studying.
All right. Thank you so much for your time, Rob, and we thank you for sharing your experiences and your knowledge regarding COVID-19 ARDS and its management. Again, for all our viewers, thank you so much. Have a great day, afternoon, and have a good night. Thank you.
Cool. Peace out. Thank you.
All right. Thanks, Rob.
All right. See you, Mike.
See ya.